Now that we understand what breast cancer is and who might be at risk, let's talk a little bit how it looks clinically and how it is diagnosed. Breast cancer can have many ways of presenting. When a patient presents to us with a new and painless mass in the breast or in the armpit, with nipple discharge, or with new skin changes, breast cancer should at least be on our differential. Of course, breast cancer can also present with absolutely no symptoms at all. These are some examples of how a breast may look that is involved with cancer. From the upper left, we see a picture that shows a slight amount of skin puckering. After that, we see masses in the upper chest wall. Then moving to the right-hand side, we see a breast that has peau d'orange or orange peel skin. And the upper right corner shows a breast that has erythema and swelling. As you can see, these changes may be very subtle, and so a good physical exam as well as a high degree of suspicion is necessary to make the diagnosis. Once any of these abnormalities is detected by physical exam, how is it that you can actually make the diagnosis? It is important to note that breast cancer cannot be diagnosed by physical exam alone. The actual diagnosis of breast cancer is made not only of diagnostic radiology, but it also must be followed by pathologic confirmation. Only tissue examined under the microscope can give the true diagnosis of cancer, and this is what we term tissue is the issue. There are 3 important diagnostic tests that we can employ for breast abnormalities from a radiographic sense, and these are diagnostic mammography, ultrasound, and breast MRI. Mammography is the first test used and is the gold standard. Targeted ultrasound can, of course, be useful to also evaluate a breast mass, and it is generally considered an adjunct to mammography. Finally, breast MRI is not generally recommended for the workup of an undiagnosed mass, and it should only be performed in areas where it can be followed by MRI-guided biopsy. In terms of pathologic diagnosis, there are several methods utilized, including fine needle aspiration, core biopsy, and incisional as well as excisional biopsy. Fine needle aspirate removes a small amount of cells and generally requires a cytopathologist to perform and prepare the slides. On FNA, it is often difficult to distinguish invasive from non-invasive cancer. And this is because the architecture does not remain preserved. Additionally, there are not enough cells to send prognostic markers such as ER, PR, and HER2. A core needle biopsy is the preferred diagnostic approach. The larger bore, hollow needle is able to remove enough tissue so that the architecture remains intact. This allows for the distinction of invasive versus non-invasive disease and can also allow for hormone receptor testing as well as other prognostics. Incisional biopsy is not the preferred method for pathologic diagnosis, as it often removes a sample of tissue, but not in its entirety, and it also subjects the patient to additional surgical risk. In contrast, an excisional biopsy removes the entire area of involvement, oftentimes with a normal tissue rim. If cancer is subsequently diagnosed from the excisional biopsy, this would be considered a lumpectomy. Not all breast cancer is the same. The biopsy will be able to distinguish cancer from non-cancer. However, it is the additional testing, the prognostic testing, which differentiates the actual type of breast cancer and helps to guide treatment decision-making. There are some benign lesions which can be found on pathology, but that confer risk of breast cancer, and these include hyperplasia, atypia, and lobular carcinoma in situ. In each of these cases, additional discussion should be had with patients about their risk, and about increased screening or chemoprevention measures that can be undertaken to reduce their risk. Ductal carcinoma in situ are cancer cells that have not invaded the ducts. This is termed stage 0 breast cancer. It is generally detected by mammography only, and currently it is thought that if it is left in place, it has the propensity to transform into invasive disease over the course of a patient's lifetime. However, there is great variability in the aggressiveness of DCIS, and it is not yet known which features best correlate with this transformation to invasive cancer. There is also a lot of controversy regarding appropriate treatment of DCIS and whether or not DCIS is even considered a cancer. Ductal carcinoma that is invasive constitutes the bulk of breast cancer diagnoses. When it is found, it is more likely to present as a mass. It can encompass every hormone receptor and HER2 receptor type and has a different pattern of metastatic potential and recurrence risk. This is in contrast to invasive lobular carcinoma, which represents a very small portion, or 10 to 15% of all breast cancer cases. Though a small percentage of the whole, it's generally harder to detect due to the single filing of the cells or this linear infiltration of cells. When it is found, the other breast should also be examined, as it has a propensity for bilateral involvement. And it's also more commonly ER positive, with the exception of one aggressive subtype of lobular cancer, which is known as pleomorphic lobular carcinoma. So in summary for this section, we'll wrap up by saying that breast cancer can present in many ways, but most commonly presents as a non-painful mass. We should have a high degree of suspicion in young women who present to us with skin dimpling, puckering, or erythema, and send them for additional diagnostic testing. Diagnosis is usually done with both radiology and pathology, but ultimately pathology or tissue is the issue. Mammography and ultrasound play a large role in diagnosis, while MRI has a very limited role unless there's also biopsy capability. Core biopsy is the preferred approach over FNA in order to perform prognostic markers. And it's important to understand, finally, that all breast cancer is not the same under the microscope or by its genomic signature. And this finding affects prognosis and further treatment decisions.